This video describes the various conditions encountered during lenticle dissection in the femtosecond laser refractive surgeries. Such one case, dissection, the patient suddenly rolls the eye up and there is a cap side cut. Now in these patients, lenticle dissection becomes a little tricky, and very carefully dissecting the base and the undersurface of the cap has to be done, and the hydro delivery comes into the rescue and the lenticle can be safely delivered, and a bandage contact lens can then be applied on the torn cap. Suction here is applied and there is a black spot both on the cap and the lenticle cut. Very careful dissection using the blunt and the pointed spatula going all around the black spot helps in dissecting the lenticle in these conditions. Sometimes during the dissection you can tear the lenticle, so I'm going underneath the lenticle, and the moment I go underneath the cap I tend to perforate at the periphery and I create a small rim of lenticle which is left. Very carefully going underneath the lenticle and dissecting and separating the retained and the torn part and ensuring it to be attached on the either side, very carefully pulling the lenticle and ensuring that it is in complete en masse helps in rescuing these situations. The suction loss during smile surgery, if it occurs during the lenticle cut where the cut has been less than 10%, you can essentially start from the beginning. But when the lenticle cut is more than 10% and less than the lenticle side cut, this needs to be converted into a flap, and then the excimer comes into play. But if the suction loss occurs during the lenticle side cut or during the cap cut or during the cap side cut, the process can still be redocked and a successful lenticle extraction can be achieved. Sometimes the patient can be uncooperative and a slight jerk can actually decenter the lenticle, but then it is not of great visual importance. Patients can be uncooperative, and if there is a suction loss that occurs during and before the side cuts, it has to be converted into a femtoflap as shown in the case. The flap can be raised and excimer treatment can then be applied. Suction loss, if occurs at after the side cuts, can carefully be managed by just marking the center and redocking the patient, and very carefully this dissection can then be achieved. So in these situations one should be very careful, because sometimes multiplanar incisions can be there, so planes have to be identified and the lenticle can be dissected very easily in these situations. So I'm going both under the lenticle and under the cap and ensuring that the planes are proper and the hydro expression comes to the rescue and the lenticle can be retrieved. Another such condition, suction, and then there is a suction loss because the patient loses their patience, and very careful one has to mark the center here because the docking all depends on the centration. So once the center is achieved, redock and the cap cut can be ensured, and once we have identified the right planes, dissecting the lenticle becomes very easy. So ensuring the right planes on either sides and the dissection being very smooth. Now this becomes a little tricky, and lenticules margins have to be seen and ensuring a complete dissection, and it can be either pulled with a forceps or hydro expressed as shown in. Another situation here where the suction once applied and you can actually see that the patient moved and the cap cut was slightly decentered. Now this is tricky because once you dissect the cap, you might end in a separate plane. So I just first go underneath the lenticle, separating all 360 degrees, and then very carefully I am trying to separate underneath the cap. Now this has to be ensured because I went from the nasal side, and then I completed the dissection of the lenticule. Now, since there are two planes here, one has to be very careful that either the plane of dissection is the same, or if the two planes are different, we have to ensure to be in the right plane and to ensure a complete dissection, and this is what is achieved here. Yet another case where we dock the patient. Sometimes loss of suction can be seen as bubbles coming in the interface, and once you have the control on the foot pedal can be stopped right at the time. Watch carefully, the suction is being applied, and on the temporal area there are areas where there are air bubbles, so I can lose the suction. And actually what happens during the cap side cut, I failed to release the foot switch at that moment, but still I continued. But then what is important is to achieve the cap opening, which I could achieve. So sometimes if you have retained lenticule, you can actually convert the cap to a flap by the circle software, and this is how the circle helps you to open up the cap. And if you have any retained lenticule, it can be dissected and removed, and then the flap can be repositioned. Sometimes staining with triamcinolone can be a big aid in terms of retained lenticules. And yes, against the red glow, so you can just dilate the pupil intraoperatively if you doubt any retained lenticule or if the dissection is difficult, because against the red glow the dissection becomes very clear, and against the red glow, as you see here, the dissections and the lenticular margins are very easy to decipher. So these are the various techniques by which lenticule nuances can be controlled, managed on the slit lamp intraoperatively. One can actually visualize the performance during the surgery. Thank you very much.